Hello everyone. In this lecture, I'm going to be talking about immune mechanism and disorders. The lecture will be discussed using this outline as shown. I'll start by telling you the introduction to the lecture. I'll discuss the immune system and then move on to discuss the different types of immune disorders that we have, and then I'll conclude the lecture. On a daily basis, as we go about our normal businesses, our bodies are exposed to myriads of infective agents, including bacteria, viruses, and fungi, from the places that we go, the surfaces that we touch, the chairs that we sit on, the tables that we walk on, even from the water and other drinks and the food that we eat. Majority of them contain bacteria, viruses, fungi that would naturally harm us. But the body is designed in such a way that these bacterial agents and all the other fungi and viruses do not make us to break down as long as our immune system is intact. From the day a child is born, some of these immune mechanisms are inherited from the mother. Some of them flow in our blood. Some of them are actually innate to individuals' baby. For example, some immunoglobulins are transferred from mother to their children, and they help to prevent this baby from falling sick in the first few months of life. On the other hand, some of these mechanisms are innate to these babies. They were born with the babies and they protect the babies from falling sick on exposure to all these bacterial agents, viral agents, and fungal agents. However, some of these mechanisms that protect us and prevent us from falling sick and succumbing to infection can also be harmful to the body. Sometimes, for specific reasons, some of these immune mechanisms can develop inappropriate reactions and begin to attack the body of the person that owns them. And it is interesting to note that some of these disorders are very common, although some of them are very mild, that they don't bother the affected individual. They might just affect the person for a couple of minutes and resolve on their own. But some of them can be so life-threatening that they could take the life of whoever is infected or affected by these viruses or infections. And these are some of the things we will be discussing in the next couple of minutes in this lecture. From the time of birth, there are several organs in the body that their function is to act as physical barrier to any form of invading microorganism. For example, the skin has a lot of keratinocytes which secrete microbe-inhibiting substances like lactic acid and fatty acid. Essentially, keratinocytes are known to secrete keratin, and the function of keratin is to increase skin thickness and prevent the entry of any invading microorganisms. But apart from secreting keratin, which thickens the skin, the keratins are also able to secrete several other substances like lactic acid and fatty acid. And what they do, what these substances do on the skin, is to create an environment in such a way that even if we have microbes, bacteria, viruses, and fungi dropping on our skin, they will not be able to penetrate and cause any form of harm to the affected individuals. Apart from these soluble or substances, the skin also has a lot of immune cells. For example, the mast cells, the Langerhans cells, intraepithelial lymphocytes, and the major function of all these different types of immune cells is to attack even if there is any bacteria or fungi or any other form of microbe that are able to penetrate into the skin. The function of these immune cells is to phagocytose them, like imbibe them and destroy them and render them powerless before they are able to penetrate and control the immune system of the affected individuals. Another very common example is the mucosal surfaces of the body. For example, the mouth, the nostrils, and other mucosal surfaces of the body, they secrete soluble substances like lysozyme, hydrochloric acid, cystatin, lactoferrin, and immunoglobulins. The function of these soluble substances on the mucosal surfaces are essentially to inhibit or prevent the growth of microorganisms, even if they find their way into the body. For example, the stomach is very rich in hydrochloric acid, which, apart from helping in the digestion of food, also prevents the growth of microbes that are able to penetrate into the GIT. As also of very important note is the immunoglobulins. Immunoglobulins are very common in all the mucosal surfaces of the body. For example, in the mouth, in the saliva of the mouth, there are a lot of secretory immunoglobulins, and their function also is to ensure that even if there's any penetration of microorganisms, they prevent the growth and multiplication of those microorganisms and destroy them before they could harm the affected individual. This is a diagram showing different organs that are involved in the immune system. For example, we can see the tonsils. The tonsils are like the gatekeeper of either the GIT or the respiratory system. They act in a way to prevent the entry of microorganisms either through the mouth or through the nose from entering into the respiratory system or getting into the GIT. That's why sometimes we have pain in our throat, which we call tonsillitis. And essentially, the reason for that is because the tonsils tend to stop all form of bacteria or viral agents that are inhaled and keep them within the tonsils and prevent them from spreading to every part of our body. The same can also be said about the lymph nodes. The lymph nodes are located in strategic places in our body, and essentially they function to prevent and stop invading microbial agents from circulating into the general body and causing an overwhelming infection. Also very important in this diagram is the bone marrow. Bone marrow essentially is the center of production of B lymphocytes that are involved in adaptive immune system of the body. We'll talk more about that in subsequent slides. The skin is one of the largest organs of the body, and essentially it creates an anatomical barrier preventing invading microbes, whether bacteria or virus or fungal agents, from entering into the body. Like I said earlier on, like there are other substances that are produced on the skin like lactic acid and fatty acid that keeps all those microbial agents from entering into the body. Also, of very important note is the mucous membrane, the nostrils, the respiratory system, the oral cavity. They are all rich in secretory immunoglobulin A especially, and the function of this immunoglobulin is to limit the entry or spread of microorganisms in all those mucosal surfaces because they are like the gateway into the body, and any form of infection in all those mucosal surfaces can penetrate into the body and become a generalized infection. So these mucous membranes have secretory immunoglobulin A that essentially stop the spread and growth of all these microorganisms from circulating into the body. This is another diagram that is essentially meant to summarize how the body immune system works. Like we all know that immune system is generally divided into the innate and the adaptive systems. The innate systems are also known as inborn or non-specific immune system because they are present in everybody. They are like we are born with them, and they can be divided into the cellular and the humoral component. The cellular innate component of the immune system essentially include the neutrophils, the macrophages, basophils, eosinophils, and natural killers. And these are essentially meant to attack any form of invading microorganisms and destroy them before they harm the affected individual. The humoral component of the immune system are soluble substances like the complement system, lysozyme, cystatin, lactoferrin, and catepsin. There are a lot more, and they are all present in soluble parts of the body, in blood, in mucosal surfaces, and in other body fluids. and essentially they are meant to attack and destroy any form of invading microorganisms in those affected parts of the body. The other type of the immune system is the adaptive immune system, which also has the cellular and the humoral component. The other name for the adaptive is the specific immune system, and they are much more specific and directed to a particular or specific kind of invading microorganisms. The cellular component of the adaptive system include the cytotoxic T cells, the helper T cells, suppressor T cells, and clonal B C cells and memory B cells, which essentially are involved in phagocytosis and production of cytokines and other immune systems that are meant to destroy essentially intracellular microbes. The humoral component of the adaptive system essentially involves the antibodies, the immunoglobulins G, A, M, D, and E, and they are able to penetrate every part of the body wherever blood or any other body fluid can flow into, and their function is essentially to destroy any kind of invading microorganisms that are found in those parts of the body. Now, as beautiful as the immune system appears to be, there are times and there are reasons and there are situations where there are problems and disorders of the immune system, and at that point in time the body succumbs to invading microbial agents. There are different types of immune disorders. Some of them are congenital or hereditary, those that we are born with. Some of them either because of genetic deletions, or some of them are passed from one generation to the other, from parents to their children. Some of them are acquired, maybe because of the infection that we have that tends to destroy the immune system, or because of drug therapy that we take for one type of ailment or the other. Malnutrition is also a major cause of acquired immune disorder. Autoimmunity is a situation where the body begins to develop antibodies against itself, which is not supposed to be. And we have a type of immune disorder that is called hypersensitivity reaction, in which there's an exaggerated immune response to invading microbial agents, which could be very harmful or even fatal to affected individuals. The congenital and hereditary deficiency are those immune disorders that occur as a result of the absence, deficiency, or defect in one of the main components of the immune system, either the cellular or the humoral type, affecting both the innate and the adaptive immune system. They are usually genetic, and then they are usually seen in infancy or in early childhood. Usually they present with recurrent infections. When you start noticing a child having recurrent infection at an early stage of life, you should have a very high index of suspicion for a congenital or hereditary deficiency. They are usually mostly treated with prophylactic antibiotics, and the prognosis depends on the section of immune system that is affected. There are different types of congenital and hereditary immune deficiencies, and they are listed above. They are grouped into like 5 different groups: the congenital B cell deficiency, the congenital T cell deficiency, the combined congenital immunodeficiency, the congenital neutrophil and phagocyte disorders, and the congenital complement disorders. There are different examples for each of the subgroups. For example, in the congenital B cell immunodeficiencies, we have the Bruton A gamma globulinemia, we have the IgA deficiency, and the common variable immunodeficiency. Bruton A gamma globulinemia is an X-linked recessive disease. Usually begins at between the age of 3 to 6 months of life, when at that point when maternal immunoglobulin begins to drop, and then the child presents with recurrent infection. If you check the child, usually they have absent or low B cells. Most times the T cells are normal, and they generally have low immunoglobulins. In selective IgA deficiency, it's one of the most common immunodeficiency of childhood. They are often asymptomatic, and they could present with respiratory infection and chronic diarrhea in affected children. If you measure the amount of immunoglobulins in the body, they usually have normal IgG and normal IgM, but immunoglobulin A is generally low in them. Common variable immunodeficiency is a situation where the B cells is unable to differentiate into plasma cells. We all know that B cells are the precursors of plasma cells. So in situation, for whatever reason, when B cells are unable to differentiate to plasma cells, it means that there will be no plasma cells essentially to produce immunoglobulins G, immunoglobulin A, and immunoglobulin M. And these are essential immunoglobulins that protect the body against infection. The onset is usually around 20 to 40 years, so they might not be detected much earlier in life. Concerning the congenital T immunodeficiency, T cell immunodeficiencies, the very important or common examples are the George syndrome, the Job syndrome, and the chronic mucocutaneous candidiasis. The George syndrome is a genetic disorder. It's usually autosomal dominant inheritance of type. And what usually happens is that there's an hypoplastic or absent thymus and parathyroid gland. In this group of patients, they usually have hypocalcemia because of the absence of parathyroid gland. And then because of the hypoplastic thymus, they usually have low level of T cells. The same thing can be said about the Job syndrome. Job syndrome is also called hyperimmunoglobulin A syndrome. It's also a genetic disorder and is usually associated with defective neutrophil and macrophages chemocytosis. In situations where there is defective neutrophil and macrophage chemocytosis, there is associated abscess formation in those children. They usually have a lot of abscess formation, essentially of staphylococcal origin. And because of the associated hyperimmunoglobulin E, the level of immunoglobulin E in the blood is very high. In combined immunodeficiencies, congenital combined immunodeficiencies, the very common and the most prominent example is the severe combined immunodeficiency, in which there is a lot of variations leading to both T cell and B cell dysfunction. It's usually an X-linked disorder, and because of the combination of both T cell and B cell dysfunction, patients usually present with recurrent viral or bacterial infection, chronic diarrhea, they have failure to thrive, and they may have absent or low lymph node or tonsils. The other prominent example in this group are the Wiskott-Adler syndrome and ataxia telangiectasia. The fourth group of congenital deficiencies are the congenital neutrophil and phagocyte disorders, and the major examples are the chronic granulomatous disease, leukocyte adhesion deficiency, and the Shediac-Higashie syndrome. What usually happens in this group of patients is that they have defective phagocytosis and they usually have recurrent infection. In a situation where patient is not able to simulate enough phagocytosis, then it will encourage the growth and proliferation of microorganisms. The last one in this group is the complement deficiency, congenital complement deficiency. Like we all know the role of complement in immune protection of the body. The major complements that are essential for the functionality of the complement system are the C3, C4, and the membrane attack complex. In a situation where a patient has deficiency of these complement systems, it exposes the affected individuals to recurrent infections. Immune deficiencies can also be acquired, and one of the common causes of acquired immune deficiency is infection. Infectious agents are able to disrupt the immunity by attacking organs and other cells that are involved in the production of antibodies, cytokines, and immune cells. And once these products are affected or disrupted, the affected individuals is no longer able to mount any form of immunity against the invading microbe. For example, in infectious mononucleosis, which is caused by Epstein-Barr virus, the virus is able to infect B cells generally and interfere with their ability to produce antibodies. And once enough antibodies are not produced, the body is susceptible to opportunistic infections, and then patient begin to have recurrent infection, unlike people who do not have the Epstein-Barr virus when they are compared. Another very important or common example is HIV infection, which is able to infect T helper cells and interfere with their ability to secrete cytokines, which are very, very important for cell-mediated immunity. And once the cell-mediated immunity is interfered with, the infected individuals is no longer able to mount any form of immunity against opportunistic infection. And that could explain why in HIV infection, the patients are susceptible to opportunistic infection. Lastly, in this group is parasites, especially in trypanosomiasis and leishmaniasis. These parasites are able to attack the immune system and prevent them from being able to mount any form of attack against invading microbes, especially in trypanosomiasis. The very common finding in trypanosomiasis is low level of complement proteins, which we call hypocomplementemia. Hypocomplementemia is very common in patients with trypanosomiasis and interfere with their ability to mount innate immune system against invading microbes. The other cause of acquired immune deficiency is drug therapy. Drugs are given or recommended to patients for several reasons, especially in patients with malignancies. They are usually prescribed on chemotherapy, and the mechanism of action of chemotherapy is usually to inhibit rapidly dividing cancer cells in the body. So the collateral damage while inhibiting the cancer cell is that it also disrupts the growth and proliferation of other rapidly dividing cells in the body, which include the immune system, the cells of the immune system. So once the cells of immune system are inhibited or prevented from rapidly dividing, the individual is exposed to opportunistic infection, and they can come down with infection that would otherwise have not affected them. A very important example is in organ transplantation, when patients are medically immunosuppressed in order to avoid organ rejection. Once they are medically immunosuppressed and they become unable to mount any form of immunity against infection, then there are a very high likelihood that opportunistic infection would intervene or supervene, and then this will result into immune deficiency. The third item in this category is malnutrition. Generally, patients with malnutrition have low calorie and low nutrients. And because of the gross protein deficiency in this group of patients, there's interference with the production of immune products like the cells and the proteins that are involved in protecting the body. And this can explain why in patients who are malnourished, they are usually unable to mount any form of immunity against invading microbes, and that is why children who have malnutrition are more likely to develop diseases like measles and diarrhea because of the low level of immunity that is associated with malnutrition that they have. The other type of immune disorder that we want to talk about is autoimmunity. As the name suggests, autoimmunity is an inappropriate immune response against self components. Usually after conception, when the fetus begins to generate cells within the body, the naive T cells are exposed to the normal component self of the body, and they are able to recognize them. Ideally, when there are any kind of cell that do not recognize the self component, those cells are suppressed within the body. They are either destroyed and suppressed so that they cannot affect self component. So there is a well coordinated regulation of clonal suppression of self reactive cells. But when there is a breakdown of these cell reactive cells, then there is a very high likelihood that the self-reactive cells will begin to attack self component. Activation of this self-reactive B and T lymphocytes cause either humoral or cell-mediated responses against self-antigens. Essentially, it's just showing that both the T lymphocyte and B lymphocyte can become reactive after the loss of regulation of clonal suppression of self-reactive lymphocyte. And when this regulation is lost, the activation of cell-reactive either B or T lymphocyte begin to react against self-components and destroy self-antigens in the body. However, the resulting disease can either be organ-specific or generalized or systemic. This slide is going to discuss some of the mechanisms for autoimmunity induction. And the first one we'll be considering is the release of sequestered antigen. Like I said earlier on, after conception, when the fetus begins to produce cells, immune cells within the body, the naive T cells are induced to initiate self-tolerance. And what that means is that the naive T cells are able to recognize all the cells that belong to the body. As a result of that, they do not attack the cells of the body. However, there are some cells in the body that are not exposed to general circulation or that are not exposed to the naive T cells because they are sequestered in other parts of the body. Because they are sequestered in other parts of the body and they are not exposed to the naive T cells, the T cells naturally does not recognize them as a member of the body. So for whatever reasons, if these sequestered antigens are released into general circulation, the T cells will see them as foreign and begin to attack them, not knowing that they have been sequestered in the body since birth. One of the reasons why sequestered antigen may be released into the body as a result of trauma. For example, if a cell or a group of tissues have been sequestered before and a patient is exposed to trauma, those sequestered antigen may then be released into circulation. Viral and bacterial infection are also very known causes of release of sequestered antigen into general circulation. And once they are released into circulation, the T cells will see them as foreign and begin to attack them and cause autoimmunity. A very important or common example is the sperm cells. The sperm cells are usually sequestered in their location in the body and they are not generally exposed to body in circulation. And if for whatever reason, maybe as a result of trauma or surgery in that region where sperm cells are produced and they leak into general circulation, the circulating T cells will perceive the sperm cells as foreign and will begin to attack them. It will develop antibody against them, and that could lead to a situation where the affected person will no longer be able to produce the antibody against the sperm, also known as anti-sperm antibody, can eventually render the affected individual to be infertile and they will be unable to produce children. The other example is molecular mimicry. What this simply means is that there could be some mimicry or resemblance between bacteria or viral agents and normal components of the body. For example, some virus or bacteria have antigenic determinants that have similar molecules as some normal components of the body. So if the body is exposed to those bacteria or virus in the first instance and antibodies are developed against them, the antibodies can as well go ahead and attack the normal part of the body that share similar antigenic determinants with those virus and bacteria and begin to cause autoimmune diseases. And one example of molecular mimicry is in what we have post-rabies encephalitis. Patients who are exposed to rabies or who took rabies vaccine usually may go ahead and develop encephalitis because of the similarity in some antigenic determinants between the rabies virus and some normal components of the cerebrum, which share similar molecular structure. So the body will develop antibody against itself, against the brain, thereby causing encephalitis because they have been exposed to either the rabies virus, which share the same or similar antigenic determinants with the normal component of the cerebrum. The third mechanism that has been indicated for autoimmune induction is the inappropriate expression of class 2 MHC molecules on normal organs. Usually, class 2 MHC molecule, that's major histocompatibility complex molecule, they are expressed on antigen presenting cells. Those are the macrophages, dendritic cells, and B cells. And their function is to phagocytose invading microbes and present them to T cells for destruction. Now imagine if a normal organ is expressing a class 2 MHC molecule. It will begin to react as if it's an antigen presenting cells, thereby initiating the development and proliferation of T helper cells that will destroy that particular organ. So essentially, inappropriate expression of class 2 MHC molecule make the body to perceive the organ on which the molecule is expressed as if they are presenting antigens, and then they are susceptible to being destroyed by the T helper cells. Typical examples are found in type 2 diabetic patients. In this situation, when pancreatic cells, the beta cells of the pancreas, when they express class 2 MHC molecule, they tend to initiate the proliferation of T helper cells, which come on the pancreatic cells and destroy them, thereby inhibiting or interfering with the ability to produce a lot of insulin for glucose metabolism. The last mechanism which has been identified for autoimmune induction is polyclonal B cell activation. Certain viral or bacterial infection can induce non-specific polyclonal B cell activation, which become reactive to cell antigens. For example, when there is an infection, either a bacterial or a viral infection, and the body usually responds normally by producing excessive B cell. These B cells, because they are sometimes non-specific and they are polyclonal, they may go ahead and become reactive and begin to attack self-antigen, thereby leading to development of autoimmune disease. A very common example is in HIV infection, where a lot of polyclonal antibodies are produced, and these non-specific antibodies begin to destroy the red blood cells and the platelets in circulation, and this can explain why in some instances HIV patients come down with anemia and thrombopenia, which predisposes them to more susceptibility to infection and bleeding disorder. This slide is essentially showing the different types of autoimmune disease as I mentioned earlier. The organ-specific ones are those that are directed towards specific organs. For example, if the adrenal cells are affected, they may tend to come down with Addison's disease. Red blood cells, if they are affected, they could predispose the patient to autoimmune hemolytic anemia. The kidneys, the thyroid gland, the muscles, the heart, and the sperm are all other organs that can be predisposed to organ-specific autoimmune disease. There can also be systemic autoimmune diseases in which the reactive T cells are generalized and circulate throughout the whole body. And typical examples are ankylosing spondylitis if the vertebrae is affected, multiple sclerosis, rheumatoid arthritis, scleroderma, Sjogren's syndrome, and lastly, systemic lupus erythematosus. The next type of immune disorder is hypersensitivity, which is a very common one, which I'm sure we are all familiar with. And this is as a result of inappropriate immune response to seemingly harmless substances. They can either be very minor or could be fatal that could lead to death. And both the humoral and the cell-mediated type have been identified. Five different types of hypersensitivity reaction have been identified, and they have been labeled type 1 to type 5. In type 1 hypersensitivity reaction, also known as anaphylactic reaction, is provoked by re-exposure to an allergen either by inhalation or ingestion. Usually it occurs within 30 minutes of exposure or may be delayed for about 12 hours. Usually when the patient is exposed to those allergens such as nuts, seafood, milk, bee venom and the others that are listed, the body reacts in such a way that they produce some agents that cause adverse events on the body. Some people are hereditarily predisposed to developing type 1 hypersensitivity, and that is called atopy. The mechanism of type 1 hypersensitivity reaction usually begins with an exposure to an allergen for the first time. These allergens are opened and presented to antigen presenting cells, which destroys the allergen and presents them to T helper cells. Upon presentation to T helper cells, the T helper cells secrete cytokines that activate beta cells to develop into plasma cells. And these plasma cells tend to secrete a lot of IgE, and this IgE binds to specific receptor on the effector cells like the mast cells and the basophils, which are carried in circulation. When there is a second exposure to the same allergen, because of previous exposure, these antibodies cross-linked on these effector cells and they trigger the release of vasoactive amines from these mast cells and the basophils. And once these vasoactive amines are released in circulation, they cause either muscle contraction, increased vascular permeability, or vasodilation. And these responses are the basis for all the manifestations that are caused by type 1 hypersensitivity reaction. An example of diseases that are known to be due to type 1 hypersensitivity reaction are the hay fever, asthma, food allergies, conjunctivitis, and some form of dermatitis like eczema. This diagram essentially is trying to show the pictorial representation of how type 1 hypersensitivity reaction works. Once, just like I explained in the earlier slide, type 2 hypersensitivity reaction is also known as cytotoxicity hypersensitivity reaction and is a form of reaction that involves antibody-mediated cell destruction. Immunoglobulin G, immunoglobulin M, and complement proteins are usually involved in type 2 hypersensitivity reaction. And what they do is to react with antigens that are present on cell surfaces of cells or in the extracellular matrix. It is called antibody-dependent cell-mediated cytotoxicity because usually the target cells are coated by either IgG or IgM before they are attacked and destroyed by immune cells. They could also be destroyed, that means the target cells can also be destroyed by a membrane attack complex, which is the final product of complement protein activation. Antibodies that bind the target cells are called opsonins in order to enable phagocytosis. It is believed that when target cells are coated by immunoglobulins, they become more predisposed to being phagocytosed, and that is why it's called antibody-dependent cell-mediated cytotoxicity. Examples of diseases that is type 2 hypersensitivity reaction, blood transfusion reaction, erythroblastosis fetalis, hemolytic anemia, and autoimmune anemia. Type 3 hypersensitivity reaction is also known as immune complex hypersensitivity reaction and is usually mediated by immunoglobulin G. There is usually the formation of antigen-antibody complex which are now deposited or carried in circulation and deposited in different parts of the body to initiate type 3 hypersensitivity reaction. These antigens that form the immune complex may either be exogenous when the source is from infectious microbes, or they can be endogenous if the individual produces antibody against self components. Once antigen antibody complexes are formed, they are either carried in circulation or they are deposited in specific organs. When they are deposited in specific organs, they cause organ specific reaction. But when they are systemic, they are carried and deposited in several organs of the body at the same time. For example, the kidney, the joint, and blood vessels can be involved at the same time. And examples of typical type 3 hypersensitivity reaction are SLE, post-streptococcal glomerulonephritis, polyarteritis nodosa, reactive arthritis, serum sickness, and adverse reaction. Type 4 hypersensitivity reaction is also known as delayed type hypersensitivity reaction. This is as a result of the delay onset of the reaction and tissue damage that follows the hypersensitivity. Unlike the other type of reaction, it is cell-mediated rather than antibody-mediated and is characterized by macrophage activation and release of several lytic enzymes that are involved in tissue destruction. Like I explained in the type 1 hypersensitivity reaction, there is usually an initial exposure to antigens in this type 4 hypersensitivity reaction, leading to a similar type of T cell activation, and this is called the sensitization phase. On second exposure to the same antigen, which is the effector phase, the activated T helper cell secrete a lot of cytokines which are meant to increase the recruitment of macrophages and other inflammatory cells. So once the macrophages have been stimulated and recruited towards the site of infection, they tend to secrete more cytokines that causes even more recruitment of macrophages. In most instances, this reaction is unable to kill the pathogens, and once the pathogens persist, there is continuous even stimulation and recruitment of more macrophages, and then the more macrophages are recruited, the more reaction is made. And the aggregation of macrophages and the changes in their structure lead to the formation of a granuloma. The massive recruitment of macrophages leads to a lot of release of lytic enzymes which cause destruction of the surrounding enzyme. Although in most situations the pathogen is still persisting and is being walled off, the collateral damage includes the release of lytic enzyme which destroys the surrounding tissue. And this is a very typical example of granuloma formation in tuberculosis, sarcoidosis, histoplasmosis, contact dermatitis, and transplant rejection. Type 5 hypersensitivity reaction used to be classified as a subset of type 2 hypersensitivity reaction because of the similarity in the mechanism of action. You remember that in type 2 hypersensitivity reaction, like I said, that in type 2 reaction, there is antibody dependent cytotoxicity. But the difference in type 5 hypersensitivity reaction is that rather than cytotoxicity, the antibody rather stimulates hormone production from the target endocrine organ. And this is a contrast to what happens in type 2 hypersensitivity reaction, in which the antibody mediates the development of cells to destroy target organs. In type 5 hypersensitivity reaction, the antibody stimulates, binds the receptor on the target endocrine organ and stimulates the release of the hormone that is produced by the target organ. Example is in Graves' disease. In Graves' disease, antibodies are produced against the thyroid gland, and once they hit the receptor on the thyroid gland, rather than destroying the thyroid gland, they stimulate the receptor on the thyroid gland to initiate the production of thyroid hormones, which leads to hyperthyroidism in the affected patient. So type 5 hypersensitivity as a subset of type 2 hypersensitivity, but rather than ensuring cytotoxicity, it stimulates target organs to produce hormones which are original to the target organ. In conclusion, in the course of this lecture, we have talked about the immune system as a means of protecting the body against invading pathogens. The body is strengthened with different types of immune mechanism, either cellular or humoral, both in the innate and the adaptive arms, and they are all essentially designed to protect the body against bacteria, virus, fungal infection, and any other form of diseases that can affect the immune system. But while these agents are doing their function or performing their function in protecting the body, some of them can perform exaggerated responses and become harmful to the body, like we saw in the autoimmune diseases and other hypersensitivity reactions ranging from type 1 to type 2 to type 5. And we also learned the mechanism of action of each of the different types of hypersensitivity reaction. Also, in the course of the lecture, we discussed that immune disorder can either be congenital and acquired, and both congenital and acquired can affect the cellular or the humoral component of the immune system. We did a review and looked at the different types of congenital immune disorders, the ones that are genetic, and we also talked about and looked at the ones that are acquired based on infections or drugs or other components, as we saw earlier in the discussion. We also mentioned, to wrap it up, that disorders of immunity can be mild, can vary from being mild to life-threatening types, and depending on the infective agent or the causative agent, the body may react in a mild or in a life-threatening way. And that is essentially the end of the lecture. I thank you all for your attention. If there are questions, I will use the next 10 minutes to attend to them. Thank you very much.